Good morning, Atlanta.
Good morning.
Fabulous. Thank you so much. Today we are sponsored by Alexion. So let's give Alexion a round of applause, please. Awesome. Thank you. Dr. Rosenthal is now the medical director of the Shepherd Center. I know that Dr. Thrower held that position for a very long time, and we're hoping that Dr. Rosenthal will do it even longer. Okay, come on up. We can't wait to hear you, all right?
Thank you. I'm happy to be here. Good almost afternoon. It's great to see so many familiar faces. So I'm going to talk about some updates in MS, NMOSD, and then MOGAD as well we'll talk about. And part of what I'm excited to talk about too is some of those nuanced differences in between MS, NMOSD, and MOGAD. It's so important to accurately diagnose NMOSD and to do so quickly. But also, even I could tell from some of the audience questions, I don't want for those of you living with MS to also think that you have that diagnosis just because solely of a lack of a test. There are other things that we look at to try to differentiate these disease processes. So we're going to go over that as well. And then lastly, we'll end up talking about just some of the optic nerve issues or optic issues in general that go along with these. All right, so currently there are over 20 MS treatments. Again, more if you include the generics and biosimilars, right? And things have changed a lot over time. If you think about the first FDA-approved disease-modifying treatment for MS was in 1993, okay? And they've evolved with regard to various factors, side effect profile, convenience, route of administration, and also efficacy. So some medicines are going to affect your immune system more or differently than others, and some we expect to work a bit better than others. So we've been able to make a lot of progress over time with what we are able to offer patients. So let's just look at the five most recent FDA-approved treatments, right? So starting at the bottom in 2019, cladribine is the brand name, is the generic name, and then Mavenclad is the brand name. So this is a medicine that was under study for a long time before it came to the market for MS, used for other types of conditions, but in a different format. And it's a unique medicine compared to a lot of the other in the group in that it offers the possibility to have non-continuous immune suppression. So this is not a medication that you take indefinitely. So for most people, it's going to be a 2-year treatment course, and it's dosed weight-based oral medication. You take 5 days in a row, month 1, 5 days in a row, month 2, and that's it for the first year. And we as your doctor are monitoring your immune system after that, and we see things change, expected changes from being on that medicine. And once things kind of come back up to within normal range, we do the same thing again for year 2. And what we find is that most people, over half, after having done that, remain stable as it relates to having MRI changes and relapses. And there is an option to retreat after the 4 years, okay? So this is a different type of medicine, and that came out in 2019. Ofatumumab or Kesimpta, this was another medication for MS. This was approved in 2020. This is an anti-CD20 monoclonal antibody, or what we refer to as a B-cell depleter. This is not a new type of medication with regard to that particular mechanism of action, but what makes this medication unique was the route of administration. Most of those B-cell depleting medications are going to be administered intravenously every 6 months, and with ofatumumab, you're able to give yourself an injection, so self-administered, convenient in the privacy of your own home, and that's once monthly. So that was 2020. And then in 2022, we had ublituximab come out. That's the brand name there is Briumvi. And this is also an anti-CD20 monoclonal antibody, so a B-cell depleter. Very similar with regard to the frequency in terms of its, I will call them cousin drugs that are also B-cell depleters. It's given every 5.5 months or 24 weeks. And there's some subtle differences with regard to its structure. and how it binds. And that's something that could be certainly talked with about, with your neurologist or MS specialist, if that's something, that you would want to have more information about. And then in 2023, this is an interesting one. So this is a biosimilar for natalizumab. It goes by the brand name of Tyruko. And again, FDA approved in 2023. I believe they started using it in Germany, maybe in 2024. And as of last month, it has been FDA approved for use in the United States. So biosimilars compared to like a generic. So a generic should be fairly identical to the drug that it's shares its name with. Biosimilars, as the name implies, it's similar but not identical. And we do see biosimilars for a lot of these biologic medications used for various indications, and there's other ones that we are using for MS as well. And then the most recent one that's achieved FDA approval was 2024, and this is Ocrevus Zunovo. Ocrevus Zunovo is the same medication as regular Ocrevus. It's not different in terms of how it works. The dosage is different because this medicine is given subcutaneously, so they have to alter the dosage so that it affects you and your body in the same concentration. It's different from, we'll say, ofatumumab in terms of its subcutaneous administration because it's not something that you could just give to yourself at home. You do still have to go in and have the subcutaneous injection, but it is still every 6 months. And it's typically given right in the belly around the umbilicus, the belly button, okay? So again, every 6 months, same indications, same medication. It's just different route of administration. So what do we still need, right? We need options for progressive disease, right? So people who are experiencing progression in between relapses. How many people living with MS and you come in to see your doctor and you're like, hey, every time I come in, you say my MRI looks fine, there's nothing new, but I feel like I'm getting worse, right? That's where we're having a lack of treatment. Remyelination and regenerative therapies, right? We've talked a little bit about, or I'm sure you know, that the damage to the myelin is what leads to the symptoms that you experience with multiple sclerosis. And any healing that happens is your own body's attempt to try to promote that healing. There's not necessarily a medicine that we can give you to remyelinate. And so to have that would be a huge deal because then you're not just trying to halt the disease, you're trying to restore function. And then biomarkers. So this is what we use to try to measure disease severity and response to treatment. It helps us to make informed decisions as we try to provide care. And then, of course, the non-pharmacologic approaches are also important. We've talked about that. We heard about a little bit about that earlier today. But dietary interventions, eating healthy, can help reduce inflammation and support brain health. Cognitive behavioral therapy, assisting in the managing of the psychological impact of MS, which can be a huge symptom for a lot of patients. Mindfulness and stress-reducing techniques that can also improve that overall well-being. And then exercise, movement. If you even just take exercise, just moving around has huge benefits for all of the above: sleep, cognition, pain, spasticity, right? So finding ways to focus on that as well. All right, so we're going to delve into NMOSD and MOGAD, and we had a great introduction about that earlier. And so again, NMOSD, neuromyelitis optica spectrum disorder. And when we talk about those hallmark features, we're really talking about its impact on the optic nerves and the spinal cord. And that is what makes it unique. So the optic neuritis, and we'll talk a little bit about that later in more detail, but it can be bilateral, meaning it's involving both eyes at the same time. That is an infrequent thing that we see in multiple sclerosis. So if we ever see someone that has optic neuritis, both eyes at the same time, we're really thinking about NMOSD. The transverse myelitis, that means there's inflammation of the spinal cord. You also can have inflammation of the spinal cord with MS. Inflammation of the spinal cord by itself doesn't necessarily mean that you have a particular, we see that on all types of things: MS, NMOSD, MOGAD, post-viral. So with NMOSD inflammation of the spinal cord, the weakness is usually involving both sides of the body. We are seeing more high levels of bladder function, a sensory level. So and this is again, not unique to MS, but if you ever have numbness that just kind of stops, maybe at a period of your chest or somewhere in your trunk, we definitely are thinking spinal cord. Tonic spasms. This is different than the spasticity that we think about, where there's some stiffness or tightness and muscle discomfort. This is where a particular group of muscles in an arm or leg is locking up, almost like a Charlie horse. Very painful, can last a couple minutes. And again, that's not unique to NMOSD, but we see it more commonly in NMOSD. Radicular pain, that's pain that almost feels like a pinched nerve, where you have pain that maybe shoots down the leg or down an arm. And Lhermitte sign. So that is that phenomenon where if you kind of tuck your chin to your chest, you may feel an electrical sensation through your body. And that's happening because if there is an area of inflammation in that neck region and you kind of make that maneuver, you're putting a little pressure on it. So it just tells you, hey, there's something there. How many people are moving their heads right now? All right. So other features that can happen are, as you heard about earlier, the intractable hiccups and vomiting. We call that an area postrema syndrome that can happen with NMOSD. It's actually the first presenting symptom in about 10% of the cases. And then the less common presentations are going to be brainstem syndromes. Brainstem is the part of your central nervous system that carries out a lot of cranial nerve functions, so like eye movement, speech, swallowing. You can get a lot of involvement of just the brain that will look different than MS. That's that fulminant cerebral demyelination. You can also get some goofy symptoms that affect the hypothalamus. And an example of that would be like narcolepsy. So those are things that we, again, don't typically see with multiple sclerosis. Then there's MOGAD. So this is myelin oligodendrocyte glycoprotein associated disease, and it can appear incredibly similar to NMOSD. It's a different protein, okay? So we heard a little bit earlier about the aquaporin 4 antibody, or autoantibody, and that with NMOSD is specifically targeting a cell called astrocytes that are really important with how fluid shifts within our central nervous system. With MOGAD, it's this myelin oligodendrocyte glycoprotein is actually expressed on the myelin. And so when it's damaged, that's how the myelin itself is becoming damaged. Again, it affects, similar to NMOSD, optic nerves, brain, and spinal cord. Clinical features are all very similar. In terms of optic neuritis, transverse myelitis, you can get encephalitis of the brainstem. You can get that intractable nausea and vomiting as well with MOGAD. And then you can get what's called an ADEM type illness. ADEM stands for acute disseminated encephalomyelitis. And with that, people tend to have this sudden onset of confusion and neurologic symptoms, and you could have seizures. And we can see that with MOGAD as well. The clinical course is interesting, and this is where we're able to try to differentiate just clinically without doing tests, is that with MOGAD, it could be relapsing or monophasic. So let's think about MS. MS, by definition, has to have some sort of change over time, right? There's either relapses or there's progression, but there's change over time. With NMOSD, it is absolutely relapsing at an incredibly high rate of relapse. So we kind of have this mindset of it's not if, but when you're going to have that next attack. With MOGAD, about half of the time, it's a one-time deal, and you don't have another attack, right? And so that makes it difficult for us sometimes after that first attack to know if you need to be on a long-term immune therapy. So it can be relapsing or it can be a one-time event. It's also different between children and adults. In kids, they tend to have more involvement of just the optic nerves and that ADEM type illness where there's a lot of confusion and brain swelling, potentially seizures. In adults, they tend to have it look a lot more like NMOSD can first present, where you only have or tend to have more involvement of the optic nerves and the spinal cord without that the ADEM where you get all of the confusion and seizures. All right. So again, we've heard this before earlier. The big takeaway with NMOSD is that there's significantly more women that present with NMOSD than men. In MOGAD, it's limited on not that much information right now, to be honest. It's a fairly new diagnosis, but we're not really seeing a difference between men and women. The age, a little different. So NMOSD in that 30 to 50 range, that is just a range. We certainly see children with NMOSD, and I've seen women in their 70s with their first attack of NMOSD. So it can present at the extremes as well, as can MS rarely. MOGAD, you kind of see this bimodal peak where you see children between the ages of 5 and 10, and then adults between the ages of 20 and 45. And as we heard earlier, there's definitely some ethnic differences in NMOSD. And at this point, we're not sure about MOGAD. All right, in terms of the optic neuritis, if you're trying to compare between NMOSD and MOGAD, and we'll throw MS in there too. Again, we've already talked about with MS, you usually only have optic neuritis affecting one eye at a time. And if both eyes are affected, there's usually one that started first and one that is a lot worse, more severe. With NMOSD and MOGAD, bilateral is more common than one side, and it tends to be long segment. So if you think about the optic nerve, connecting your eyeball to your brain, the length of that inflammation tends to be more pronounced with these two disorders compared to multiple sclerosis, where it's usually a short segment. And then we talk about this posterior anterior involvement. What we mean by that is with NMOSD, it's usually the back part that attaches to the brain. And with MOGAD, it's usually the part that attaches to the eyeball, which is important to us because when we look in your eye or the eye doctor's looking in your eye, you're more likely to see changes with MOGAD, whereas with NMOSD, the eye exam may look normal from looking at the optic disc. There are other changes that you can look at to see if there's optic neuritis, but the disc itself may look completely normal. With the transverse myelitis, with both NMOSD and MOGAD, it tends to be longitudinally extensive. What do we mean by that? It tends to be at least 3 vertebral segments or longer. With MS, they're usually short segments. They're usually kind of put off to the side, which is why with MS, when there is a spinal cord inflammation or lesion causing symptoms, it may just affect one side of the body or it may not have as pronounced symptoms. With these, it's taking up a longer part of the spinal cord and a larger diameter of that cord, so the symptoms tend to affect the whole body and be more pronounced, more severe. With MOGAD, we tend to see the lower part, the thoracic and like the bottom part of that spinal cord more involved. And with NMOSD, we see it more in the upper and mid spinal cord, but there's overlap. So this isn't just one or the other. Now, with the outcome of the spinal inflammation with MOGAD, what we tend to see is that they recover a lot better. So it's very severe attacks, but they recover a lot better. And with NMOSD, severe attacks that don't recover as well. And then the brain syndrome. So we've already talked about you could have brain and brainstem involvement with both of these syndromes. We tend to see, again, just to reiterate, more commonly that area postrema syndrome, which is that nausea and vomiting type presentation with NMOSD. And then that ADEM kind of confusion, seizures, brain syndrome, we tend to see more with MOGAD. And so again, this is just reiterating the disease course between NMOSD and MOGAD. NMOSD, it's relapsing. It's not if, but when. We want to get you on treatment immediately. MOGAD, it could be a one-time attack, so maybe we're not sure if we need to put you on long-term immune therapy. Both have severe attacks, but the recovery with MOGAD tends to be a lot better than the recovery with NMOSD. And then interestingly, compared to MS, these are more attack-driven diseases, so we're not seeing much in the way of progression in between attacks, whereas when someone living with MS may have other symptoms that are going on between attacks, there's usually no symptoms that are developing in between. So there are antibodies to both. We heard about earlier about the cell-based assay to look for those, the antibodies to the AQP4. And so with NMOSD, that first became commercially available to test on patients in 2004, and then they incorporated it into the diagnostic criteria for NMOSD in 2006. So we're talking within the last 20 years. Before that, they were diagnosing without that antibody testing. So things look a lot different now, and it's actually a lot easier to make the diagnosis confidently with that antibody test. There are also antibodies to MOG, so myelin oligodendrocyte glycoprotein. This first became commercially available for testing in 2017. That's not that long ago, and it was incorporated into the diagnostic criteria in 2023. So this is why we don't know as much about MOG. It used to be thought that when people had these antibodies to MOG, that it was under the MS umbrella, which frankly, they used to think of NMOSD sometimes as being under that MS umbrella, but what we know that these are now distinct syndromes with their own set of criteria and rules. These are busy slides, but in terms of the criteria, the big takeaway here is that for NMOSD, if you're worried about diagnosis, you have that positive antibody test and you have a symptom that goes along with it, whether it's any of the things we talked about, the optic neuritis, the transverse myelitis, right? And then you have it. If someone comes in, because there is differences, or excuse me, overlap between MS and NMOSD. If you come in and you have one of these neurologic symptoms in a positive antibody test to NMOSD, that's what you have. I'm not going to entertain MS because that antibody is so strongly associated with the disease. What's more recent is that this whole concept of seronegative NMOSD. So they say about 85% of people with NMOSD are going to have that antibody. What about that 15 or so percent that does not have the antibody? That's what seronegative NMOSD means. And just at our recent conference, they are now revamping the diagnostic criteria for NMOSD. And what they're talking about is kind of getting rid of this the seronegative NMOSD diagnosis, and just kind of having this seronegative category of itself, seronegative for NMOSD, seronegative for MOGAD, but not necessarily having it fall directly under that NMOSD umbrella. So to be determined on that one, but it is incredibly, when you start to talk about seronegative NMOSD, it gets very confusing and complicated because we don't have as much information to go off of. And then you're talking about a subset of what's already considered a rare disease. So the dilemma is, if they're negative, is we want to put someone on the right treatment because there are certain MS therapies or therapies that we use that can worsen NMOSD. So those need to be avoided. So that's why an accurate diagnosis is important. And then what if someone's negative? Should you repeat those antibody tests? Should you do it again? And how often should you repeat those tests? Those are things we think about. And then if you think about seronegative NMOSD, again in quotation marks, there are no FDA-approved treatments for that. And so just finding ways to manage that can be difficult. So early diagnosis of NMOSD is so important. And again, there's been a lot of efforts to try to promote education to neurologists and ER doctors and primary care doctors and ophthalmologists, since those are oftentimes who these patients are first seeing. And again, it's because there's such a high rate of relapse with NMOSD, which can give you a high risk of disability. Again, we've already mentioned that the recovery after these attacks can be poor, and we want to avoid those inappropriate treatments. We don't want to mislabel somebody with MS and put them on a treatment that could potentially worsen NMOSD. So again, a high rate of misdiagnosis, and the vast majority of these patients are misdiagnosed as having multiple sclerosis. And as we heard about earlier, other autoimmune disease, some of these patients are misdiagnosed as lupus, or they go into the ER and it's thought they have like a viral gastroenteritis because they have vomiting and nausea. Sometimes it's misdiagnosed as depression, right? So working on trying to get accurate diagnosis. There was a study that looked at the barriers to diagnosis with NMOSD, and what they found were the biggest barriers were the atypical presenting symptoms, so the nausea, the vomiting that someone would maybe necessarily attribute to a neurologic disease. Time to MRI. So if someone got an MRI earlier, they were able to get an accurate diagnosis earlier. the time to a neuroimmunologist. So if you're able to see a neuroimmunologist, usually diagnosed more accurately and more speedy. And then that time to antibody testing, again, specifically that cell-based assay. All right, here's the MOGAD criteria, which I put up because there are some important differences between the significance of the antibody with NMOSD versus the significance of having that antibody with MOGAD. With MOGAD, if you have a positive antibody test and you have the symptoms to go along with it, then you may have MOGAD, but that positive antibody test has to be of a certain level, has to be high enough. There are lots of people that are walking around that probably would test positive for MOGAD at lower titers, and they don't have the disease and they never will. So we want that, and that's compared to NMOSD, where if you do have that antibody, we kind of say you have NMOSD, right? They're very closely tied. That is not the case with MOGAD. So if somebody, their antibody level falls below a certain range, there's additional criteria that need to be met, and you have to take a really hard look. Does this person actually have MOGAD? I have patients that I follow with MS. They have MS, but they've got low MOGAD titers, but it's MS. I know it's MS, and it doesn't look like MOGAD. So just because you test positive for MOGAD does not necessarily mean you have, or excuse me, just because you test positive for MOG, I should say, does not mean that you have MOGAD. And that's an important distinction. All right, immune therapies. So if we're looking at NMOSD, we currently have 4 immune therapies to offer for our patients that are FDA approved. And this is fantastic. The first one was in 2019, which was not that long ago, right? So prior to that, we were using a lot of off-label treatments, which you can see below. Rituximab, tocilizumab, mycophenolate, and azathioprine were some of the ones that we're using. But now we have 4 treatments, and the most recent one came out in 2024. MOGAD, on the other hand, we've already established is fairly new, and there are currently no FDA-approved treatments for MOGAD, so everything that is used for treatment is off-label, and those treatments include, similar to what I've already mentioned, that was off-label for NMOSD, but I'll add that we use a lot of IVIG and extended prednisone tapers as well for these patients. There are currently 2 trials of medicines, 2 clinical trials that are looking at immune therapies for MOGAD that we're looking forward to hearing the results, next year or the year after. So this is just a little more detail about the NMO treatment options that are available. So the first one is eculizumab that came out in 2019. This is an infusion that's given every 2 weeks. And one of the caveats here with this medicine is that you do have to receive a meningococcal vaccine, and it's what we call a complement 5 inhibitor. And with that, you are at a higher risk for meningococcal meningitis. And so these patients do have to be vaccinated before they start taking it, or we need to treat them preventively until they're able to get the vaccine if the medicine needs to be started urgently. Ravulizumab, or Ultomiris, came out last year, and it is a very similar medication in terms of how it works, the mechanism of action, but it has a more convenient dosing regimen. It's every 8 weeks. Every 2 weeks can be incredibly disruptive to someone's life, especially if you are, taking care of your family, working. It's a lot, or you have difficulties, getting to appointments or require transportation, right? So every 8 weeks works a lot better for a lot of patients, but still must have that meningococcal vaccine. And nebulizumab came out in 2020. It is a B-cell depleter medication. It is an infusion. It's given every 6 months. And then in 2020, also, we had the FDA approval of satralizumab, which is an injection that the patient can administer to themselves once a month. So we have now 4 FDA-approved treatment options for patients living with NMOSD, and they all performed great in clinical trials. All right, so as we wrap up, I'm just going to talk a little bit about just optic issues in general that you could see between MS, NMOSD, and MOGAD. Again, it's very rare that you see a symptom that is owned by any one of these conditions, so they can present very similarly. So when we talk about inflammation of the optic nerve, here is the optic nerve, right? So it attaches the eyeball to the optic tracts within the brain, and the inflammation can happen anywhere along here. Okay. And so when we're looking at your MRI, sometimes we can see that optic nerve. It may be difficult to see here, but there's an optic nerve here and an optic nerve here. And you can see right here, this lighter area there's a lesion, there's inflammation of this person's optic nerve, right? So sometimes we can see it, sometimes we can't, but that's part of what we're looking at when we look at the MRIs. Is there areas of inflammation anywhere along that track? So what are the symptoms of optic neuritis? One of it is eye pain. And it's usually pain with movement, which makes sense. If the optic nerve is inflamed and you're moving it around, it's pulling. And so there's some pain associated with that. An afferent pupillary defect. This is when we're shining that light in your eyes and going back and forth. What we're looking to make sure is that when we shine the light in your eyes, that the normal reaction happens, which is that both of the pupils should go down. If someone has had optic neuritis, that light is not reaching the brain appropriately, and so the pupils don't respond the same way. So that's what we're looking for there. Central scotoma is just a blurring of the central part of the vision. That can sometimes be the first symptom of optic neuritis, even before the pain. Photopsia is where you're seeing like tingling, that's a sense, right? Tinsel. Sparkles, that sort of thing in the vision that can happen about a third of the time. Loss of color vision, in particular, red colors not appearing as vibrant are common with optic neuritis. And papillitis, again, that is when we can look at your eye with the ophthalmoscope and see inflammation of the optic nerve disc. So that's how it can present acutely. In the long term, there can be persistent visual loss. As you've already alluded to, you're less likely to have that persistent visual loss with multiple sclerosis, especially if the optic neuritis happens early on in your MS course. Whereas with NMOSD, the risk of persistent visual loss is going to be a lot higher. Light sensitivity. So we've already talked about how if that pupil isn't taking in the light correctly, the pupils don't come down appropriately. And so now we've all been in a situation like if you're driving at night and there's an oncoming car that's really bright and your eyes are confused because when it's dark, your pupils should be nice and big, but then when there's bright lights, they should go down. And now your brain is confused and you're like, oh, it's so much, right? That is what's kind of happening, that light sensitivity that can happen when your brain isn't interpreting things appropriately. Color desaturation, we've talked about, that can persist in the long term. Uthoff's phenomenon. So this is the phenomenon where if the body temperature goes up, you may have a recurrence of neurologic symptoms. And in this case, we're talking about optic neuritis. So it's not uncommon if someone has had optic neuritis in the past and they say things got a lot better, but they get overheated. Maybe they have a fever or they're just outside in the middle of summer in Georgia, or took a really hot shower, or they're out running around. They may say, okay, my vision is starting to get blurry in that eye again. It does not mean there's any new or recurrent inflammation. It is simply a phenomenon that happens because your body isn't able to compensate for that as well when you're in those circumstances. And then optic atrophy, that's something that we're able to see on the MRI or when we look on your eye exam, that the optic nerve actually looks different from the scarring that has happened. So again, we've talked a lot about this in terms of the variable clinical presentation. So something else that can happen with these is diplopia or double vision, seeing twos of things. And this is due to the eyes being misaligned. In order for us to use both eyes to see one image, they both have to be in sync and moving in sync. And if the muscles innervating one eye are weakened because of a brain problem, or a cranial nerve problem, now you have got one eye looking at one thing and another one looking at another, and that's when you start to see twos of things. And it's not always obvious to the naked eye, right? Sometimes if someone's got a huge misalignment that you can see that, but even just things being off by a couple millimeters can cause a blur or images to kind of sit on top of each other. And so that's what we mean by double vision. So double vision, in this case, we call it binocular because it's both eyes are the problem, is from that misalignment. And the way you can tell if it's happening is if you cover one eye, you should see one image, okay? If you cover one eye and you're still seeing two things, that's an eyeball problem. That's not what we would necessarily expect with MS and NMOSD or MOG causing a misalignment. And again, this is just showing where it comes from. So you can see these are the muscles that control the eyes. They have to work very well. There's different muscles working very well to allow us to keep our head straight and look around a room. And again, if any of those muscles are compromised in any way, you can get that double vision. Intranuclear ophthalmoplegia. Now, we always say that, again, with these MS, there's not one single symptom that is unique to MS. But if I had to pick one that would really make me say, I'm going straight to MS, it's this one, intranuclear ophthalmoplegia. And this comes from a brain stem lesion, and it's right at the area of our brain that allows us to look from side to side. And so what happens when there's a lesion there is that when you look in a certain direction, one eye is weaker. And so that's why you can have this kind of phenomenon where you have a weakness on one side. It rarely ever looks this obvious. It's something that we test when we're looking at eye movements. Sometimes it could just be a subtle lag in one eye, but that is something that's highly suggestive of multiple sclerosis. And then nystagmus. This is going to be due to a brain lesion. Nystagmus is kind of this rapid, repetitive shaking movements of the eyes. It can be very distressing to a patient to have to deal with it. And when it's coming from the brain lesion like this, it can be up and down, it could be side to side, it could be torsional, and it is incredibly difficult to treat. When we have some patients coming in with this particular symptom, it's rare that we're ever able to give a medication or a treatment that is able to completely alleviate it. All right, and so I think we've had most of these resources already listed, but again, the Samara Foundation's fantastic, Guthrie-Jackson, SRNA, and there's also the National Organization for Rare Disorders. All right, and that's the completion of my talk.
Okay, do we have any questions in the room? If not, I'm going to start with questions that are online. Okay, great. First off, thank you very much for doing the presentation. First thing that person wanted to ask was, why would a person doing well on Tysabri switch to Tyruko?
I agree. Why would they? That's my general approach. Okay, a truthful answer though would be insurance. When biosimilars come out, insurance finds that they're cheaper, and so they will oftentimes require that we switch patients. But to the person who asked that question's point, there is absolutely no reason to switch from Tysabri to Tyruko from a clinical indication.
Okay, that being said, if an insurance company wants the patient to switch from Tysabri to Tyruko, how can they guarantee that they're still going to respond the same way?
At this point, without knowing about the medicine in terms of it's the efficacy and also the monitoring standpoint in terms of monitoring the JCV index levels. It's hard to answer that question, but the truth is you don't know. And there have been times with biosimilars in the past that have come out and we put someone on a biosimilar and then we decide, oh, you're not doing as well on this one and we need to do something else. And so it's very difficult to predict. And I don't have experience with Tyruko at this point. Again, it just became available a couple weeks ago in the United States. But at this point, I'm going to continue prescribing Tysabri.
There are many different genres of MS medications. Are you able to tell us the differences between the different types?
Yeah, a little bit without taking up. I could talk about that for hours. So we try to describe these medications in classes to an extent. And so there's that. So when we talk about anti-CD20s or B-cell depleting medications, those are going to be your ocrelizumab, your rituximab, which is off-label, your ublituximab, and your ofatumumab, right? So we all kind of treat those the same as a class effect. And then you have your S1P inhibitors. So that's going to be your Gilenya, your Mazet, your Ponvory, your Zeposia, right? So we cluster all of those together. And there are differences in terms of how they work with regard to efficacy, side effect profile. Some we consider to be more immune suppressant. They're actually taking away or depleting a cell line. So like B cell depleters, for example, are going to be more than that immune suppressant. There are other medications that we think of as more immune modulatory, and we're getting into semantics a little bit here, but the big takeaway there is if somebody is at a high risk for infections or has other immune conditions that we're worried about, we have to take that into account. So we do try to put them in classes as best we can, and we look at the differences in the features of it as a class, and then we also look at it in terms of efficacy and whether it's more immune suppressant or immune modulating.
Okay, thank you for that. Speaking of that, there are people in rural America that are told that they should remain on low efficacy medications such as Copaxone, just because the doctor might be more familiar with that. How do we teach those in rural areas around the U.S. or the community doctors in those areas about the high efficacy treatments?
So there have been a lot of efforts to reach these neurologists that are serving underserved areas, rural communities, to let them know there's mounting evidence to show that higher efficacy treatments give you a better long-term outcome, which doesn't mean that the low efficacy treatments shouldn't be used at all. There are situations where we do use those treatments and they are appropriate, but it is going to be more and more education. I do think that MS has evolved, but there being so many treatments that sometimes it's very difficult for these community neurologists to have a good appreciation and understanding for all the nuances of these newer medicines, in which case that is the benefit to seeing a neuroimmunologist or an MS specialist. But I completely agree. You're kind of stuck between a rock and a hard place because of issues with access. It's not always possible for everyone.
Great, thank you. Next one is about step therapy. Are doctors still actually using step therapy?
They are. I think that there's definitely been a move towards using high efficacy treatments from the beginning, but there are still doctors that do use step therapies. Yep.
Okay, next one. For those that don't know, and again, going back to community doctors that are not aware that their patients are not responding to MS medications, how do they get more knowledge of NMOSD or MOG?
The patients or the doctors? Just the resources we have here. I know that there's been outreach from pharmaceutical companies and other, the resources that were just listed here in terms of providing education. I can't go back. But these are organizations where they're really dedicated to spreading the word. I know that we've had discussions in the neurologist community about trying to touch base with, again, ER doctors and ophthalmologists and that sort of thing, so they know that you can order this antibody test and that will give you your answer.
Okay, thank you. Great. Awesome. Well, I'll make my way there. Can you tell us about what's happening with stem cell therapy?
With stem cells currently?
Treatments.
Well, I think at this point, we know that stem cell treatments work for multiple sclerosis. There's been some studies looking at stem cell and NMOSD as well. But again, it's a rare disease. So the big takeaway, if nothing else with NMOSD, it's very hard to get treatments because of the studies, getting enough patients to study in those treatments. But I'll say for MS, it's definitely been shown to be effective. And when I say that, I'm talking about the autologous hematopoietic stem cell transplants. There are some patients that are going to get these treatments done, in other countries, and that creates a little bit of a dilemma for us in terms of just making sure we know what protocols were being used. But I find that as time has gone on, these protocols are becoming more defined, which I think is a good thing.
Great, thank you.
Okay, I want to circle back when you discussed about optic neuritis, and if you've had that in the past, but I find if a person can overheat, does that cause pain still in the eye? Does that make sense?
Sorry.
Oh, no, I was just going to say, does that make sense in any type of way?
Yes. Yeah, so I think we've talked about it with optic neuritis, but it could happen with any symptom. So if you take somebody that doesn't live with one of these neurologic conditions, completely neurologically normal or intact, and your body temperature goes up, you're going to have a reduction in neural transmission. That happens with everybody, no matter what. But an intact neurologic system, you're usually able to compensate for it. You may feel tired, you may start to feel a little brain fog, but you're not having a specific neurologic symptom anywhere. But someone with MS or NMOSD or MOGAD that has a history of scarring in somewhere, where it's your optic nerves or a pain pathway or a bladder pathway, now that neural transmission has slowed down, maybe it's not going through at all, and now you have this symptom that has come back. But when it happens, you're not hurting anything. There's nothing new or worsening. It's just a phenomenon that happens when your body temperature goes up. It comes up a lot with people when they're trying to exercise and they're like, okay, I'm exercising and now I can't see, or I'm having this pain, or my foot is dragging. And again, it's not making anything worse. So now we just have to work it from a standpoint of safety and making sure that you're able to do modifying those activities in a way that works for you on a very individualized basis.
Good. She understands. Great. How does Uthoff's phenomena for MS affect those with NMOSD?
So MS doesn't own it, right? So I think it's the exact same phenomenon that's happening with NMOSD.
Excellent.
My question is with regards to CAR T cell therapy. Are you familiar with that? And can you speak a little bit about that if you are? And a follow-up question to that is are there any studies or research studies being done in the Atlanta area with regards to that type of therapy?
I don't know that they're doing anything in Atlanta right now. I know at Shepherd Center, we've certainly been in some discussions and are trying to get involved in it. So CAR T therapy is a therapy that I would say we're all very excited to know about and to learn about. It's basically where they're taking some, just generally speaking, parts of your immune system and kind of modifying it and to give it back to you so that your immune system is behaving better as a whole. And I think it's exciting. I'm looking forward to it. In terms of Atlanta right now, I don't think, that Emory's not doing any that I'm aware of. Shepherd Center is not right now. I'm hopeful that we will be able to get started.
So my answer for her, clinicaltrials.gov.
Yes, clinicaltrials.gov will give you that information. Those types of studies, we have to work very closely with our hematology colleagues, and so there's all of those things have to be put in place. But I think it's exciting, and I'm really hopeful to get involved with it.
Did you have a question?
Okay, my question is that since we know that depending on where the lesions are on the nerve tract, and that controls, and I understand that it controls certain parts of our body. So if we have it, say, on an area that's affecting whether we're moving our left arm properly, is it possible to retrain so that it can start back moving the way it needs to move?
Well, yeah. I mean, I think you're also kind of hinting at, we throw that one of the terms is neuroplasticity and kind of your body's ability to form neural pathways. And there's not a medication yet that I can give you to promote that healing or to promote new pathways. But there's been a lot of evidence about exercise. And that's a huge part of why we want patients to do physical therapy, occupational therapy. You're promoting those new pathways through movement.
So just by continuously doing that motion is going to help.
Yeah, your brain is trying to fire, and it's like practice. It's exercising the brain.
Okay.
Yeah.
Actually, that's so exercise physiologist here. And I was actually that was my question. I was gonna ask you to speak to the benefits of exercise and while exercising, connecting the mind to the muscle when you're doing that. So if you wanna piggyback on that and maybe
You already know you're the best
expound.
person to answer that question.
Well, it's a combo thing. And so I definitely, just from experience and working with patients who are experiencing MS and NMOSD and all of the above, the benefits of continuous movement, and of course, pairing it with your function level, because everybody it presents so very differently. But there are definitely benefits to that. And then I also wanted to ask you about the nutritional part. From your side, are there more beneficial diets for those who are experiencing MOGAD, NMOSD,
Right.
MS?
So first, from the exercise part, I'll add that when that attack first happens, we're kind of in that acute phase. That's when the movement is so incredibly important in terms of any gains you're going to have. That's why we feel so strongly about individuals doing rehab, but then just continuing movement in the long term. If somebody, has a mobility impairment and, isn't able to walk around as much, we do expect there's going to be some weakness just from disuse itself. And then it gets very difficult to differentiate what this progressive weakness due to not moving versus the MS disease state. And we want to make sure we're like making medication decisions based off of what will actually be useful to the patient. So movement is always so important. And there are a lot of resources out there and things that you can do if you have mobility impairments to try to for exercise to meet you where you are. From a diet standpoint, the diet that we recommend most is going to be a heart healthy diet. There's so much stuff out there about MS diets. Some of them are very restrictive. I don't typically routinely recommend those kinds of diets. When we talk about a heart healthy diet, we're kind of talking about more like a Mediterranean diet. So lean meats, healthy fats, lots of fruits and vegetables. There's such a close interaction between MS severity and cardiovascular risk factors. So if somebody has uncontrolled cardiovascular risk factors, and by that I mean uncontrolled high blood pressure, high cholesterol, diabetes, if someone's obese or using tobacco, smoking cigarettes, all of that can affect the vasculature to the brain, and that causes lesions as well. If you look at MRIs on everybody in the world, you're going to see lots of brain lesions, and most of it are going to be from those cardiovascular risk factors I just mentioned, right? So if you're already living with MS, which we know causes brain lesions, you really want to limit that cardiovascular disease related brain lesions as well, which can worsen MS. Aside from that, this is just Jackie's personal belief here in terms of diet, that it's very individualized. I do think that certain individuals have sensitivities to certain groups of food, and for them it does make a difference in how they feel, and it may make a difference on how the disease itself behaves. But I think that's something that I don't know that there's going to be a one size fits all in that way. I recommend patients, if they want to experiment with diet, to maybe kind of take one thing out at a time, maybe for 2-3 months, a long enough time to really know if they feel different and if things are different. And if not, then I really don't feel like people should live without whole food groups if they don't have to.
And one more thing, I wanted to ask: is that something that's presented when there are patients that are coming in? Is that presented on the forefront in an initial consultation or upon first being diagnosed, to mention those things as far as, hey, in addition to treatment, exercise, diet? Is that something that is pushed more now than maybe before?
Oh, generally speaking, absolutely. There was, again, a time in the past where I think MS patients were told they shouldn't exercise, which is horrible. MS patients should absolutely exercise. We do talk about it as a part of the entire treatment. Do we always cover it all in the first visit? It depends on the patient. Sometimes it's just so overwhelming. We have to kind of slowly introduce things. And maybe at that point, it's most important to get on the treatment, and we'll kind of tackle sleep, diet, exercise, and all of those other things later. But I would say it's ultimately going to be just as important.
Going off of that, why aren't statins used more often then for the MS community?
That's a good question. I think that there's been some research or some thoughts about that. I think that there's been discussions about how actively involved should us as MS specialists just be in controlling cardiovascular risk factors. I don't necessarily always prescribe the statin, but I do pay attention to my patients' cholesterol, and if it's high, I do have them kind of, talk with their doctors about getting on treatment. But maybe that should be something that we take more active management in.
Okay. Another one is, for those with swallowing difficulties, can you explain to people why they would be recommended to see a speech language therapist for a swallowing problem?
I think there's a general misunderstanding about all the things that our speech therapists can do. They certainly help with speech. So slurred speech or, difficulty getting words out, but they also do swallow evaluation. So they are kind of dealing with all of the muscles that control the mouth, the neck, throat kind of area. So they are who we refer to for swallow evaluations. They do tests. They could they could actually do radiographic tests to see the mechanics of the swallowing and where that problem is coming from. Speech therapists also can work on breathing, just more functional breathing. So they do a lot that don't necessarily go along with what the name speech therapist implies.
Person wants to know what's the difference between the octave testing and SNFL testing. And we're not talking about football.
The RNFL,
The octave is the MSDA
the Octave MSDA testing. So I'm sorry.
versus
NFL.
NFL,
Okay,
yeah.
got it. So NFL, neurofilament light chain, is a blood test that has been associated with more inflammatory disease. It's not specific to MS. They've looked at it in a lot of different autoimmune illnesses. But I talked earlier about us needing more biomarkers to help us make decisions. And so that is one of the biomarkers we look at. If we will get that test, and it gives us maybe some information about how active or not inactive a patient's MS may be. The Octave Serum MSDA, that's Octave MS Disease Activity Test, is a test that looks at over 20 different biomarkers, which includes the serum neurofilament light chain. It's a blood test, so it's a little bit more extensive, and it looks at all of these biomarkers, and it kind of spits out a score. That score is going to be low, moderate, or high. And if it's low, it basically implies that the person's risk of having an inflammatory attack within the next year is very low. If it's high, it insinuates that there's a high risk. And if it's moderate, I will be honest, I'm not quite sure what I personally am doing with those patients just yet. It's a little less useful to me. But again, to get that test score, and if it's low or high, it's very helpful. But that Octave MSDA test includes the neurofilament light chain test. It's more extensive.
Right. How are you using that, though, to control what medications you're having your patients be on, or to look ahead if you see that they're going to be demyelating a little bit further?
I probably use it most commonly right now if I'm taking someone off treatment for some reason. Maybe the treatment's causing a problem, or there's a side effect, or they've been dealing with MS for 30 years and we need to de-escalate treatment. I'll get it to prove to myself and the patient that we can rest assured if that score is low, we can feel more confident about remaining off treatment. I've also been using it just for new patients before I even get them started, to have as a baseline to compare to. So if you get a brand new MS patient who's never been on treatment, you would assume it would be a high score. You put them on treatment, it should go down and stay low. So there's lots of different reasons like that we use it.
Thank you. Which leads to another question. And with aging and MS, a lot of MS neurologists, a lot of community doctors are taking patients off of medications when they get to a certain age. But why would you, if it could be that the medication is keeping them from getting worse?
It's hard to know when that point is for everybody. So this is a complicated question, and there's never going to be like a one size fits all. If you get to a certain age, you stop treatment. Because people are different biologically, and the MS is different from individual to individual. But if you look at the natural history of MS, it tends to be very active in the beginning. That's when you're more likely to accrue brain lesions and have new symptoms. If you kind of look as a timeline over time, those new brain lesions and those new symptoms or relapses tend to become less and less frequent. So if you've had MS for 20 years, you're probably less likely to have relapses at that point. The treatments we have work very well at stopping new symptoms and stopping new brain lesions. They are not great at stopping the progression. So if we know that it's more inflammatory with relapses in the beginning, and you're more likely to maybe deal with some progression at the end, at some point our concern is that the medicine may be causing more harm than good. And when that flips, then we have to start thinking about taking someone off, because it may get to a point that the medicine is not helping and maybe hurting. You put that in combination with the fact that as we age, our immune system is naturally getting weaker. So if I have someone that's been dealing with MS for 30 plus years, they're in their 60s, and now they're hospitalized with a severe infection, or they come in and they're like, I'm dealing with this sinus infection all the time, or there's something going on, I'm going to start to ask myself, okay, I don't know if this medicine's probably hurting this patient and not helping them anymore. But to the person who asked the question's point, sometimes we don't know when we take someone off treatment because we think it's causing a problem, and then maybe there is a new relapse that happens. That's not the norm when we try to use the information, the tools we have to make these decisions. But that goes to the fact that it's an unpredictable disease and it's different for everybody. And ultimately, what we're trying to do is make sure that if we're giving you treatment, it's to help you, and that the chance of helping is going to be more than that chance of hurting or causing problems.
That being said, are all MS medications should be known as immunosuppressants?
Again, so I would say no, right? If you look at, glatiramer or Copaxone, someone brought that up earlier, we wouldn't consider that an immune suppressant medication. It's not suppressing any particular part of the immune system, but it does modulate how the immune system behaves, where it's trying to make it less inflammatory, to change that ratio between the pro and anti-inflammatory parts of the immune system. And again, at some point, this becomes kind of difficult to tease out with what each drug is doing, but we certainly think of certain drugs being more immune suppressive.
The only reason why I bring that up is because a lot of people concerned with us now going into the flu season again, should they be out in public if they're taking a high efficacy medication? And Copaxone not being high efficacy, but what about the high efficacy meds?
My general approach is that these medicines you should be able to take the medicine. It's to add to your quality of life, not take away from it. And so if you're at that high of a risk for having a bad outcome from flu, that I'd want you to quarantine, we would have a discussion about whether that's the best treatment for you. We all should use common sense in the flu season and, get our shots and mask if maybe we're in certain places or situations. But I generally speaking, I don't have patients even on high efficacy treatments ever quarantine or take special precautions to that extent.
Right. So you said part of my next question, and could you tell people why they should be using vaccinations?
So I know these vaccines, especially flu vaccine, gets a bad rap, but it's not 100%. Our MS treatments aren't 100%. Most things in medicine aren't 100%. And the flu vaccine is designed to, so that even if it's not, you may still get the flu, but what we don't want is a severe infection. We don't want you to be hospitalized or have breathing problems from that infection. People die from the flu. And so that's the importance of the flu vaccine, is we really are trying to, again, limit the potential bad outcomes that could come along with it.
So in addition to the flu vaccine, should they also get RSV?
For RSV and COVID and, pneumonia and shingles, all of that, I would say that it's not a bad idea to get them. Or the way that the CDC's language is that if you're on an immune therapy, you don't have to follow necessarily these age guidelines that are out there, have to be in a certain age to get vaccines. I don't, there's a little bit of a case-by-case basis in terms of, do I have strong opinions about getting those vaccines? But I do think if you're within that recommended age range to get the vaccine, absolutely, you should get it.
Thank you. Last question. Current research, and AI technology. How will AI benefit what's going on with MS research?
I think probably the first thing that comes to mind is going to be with our MRIs. That's something that I think we're already using a lot. We're starting to use even in clinical practice, which has been fantastic. I don't know that, when I think about artificial intelligence, in terms of it maybe facilitating like algorithms in terms of which disease modifying treatments, I don't know where that's necessarily going, but when I look at MRI radiograph, for example, I think that can be really helpful.
Excellent. Any questions? Then we're done. It's a wrap.
All right.
Thank you.
Thank you.
All right. And that's it. I want you all to have a happy holiday season and stay safe. And remember, get your vaccines if you wish.